So the BRUIN study was a phase 1-2 study in patients with relapsed and refractory B-cell malignancies. And I updated the results for the Mantle cell lymphoma cohort on that study. So that was about 166 of the 773 patients. We focused on 90 patients who were in the primary analysis set, and these were patients with covalent BTK inhibitor treated disease. The BRUIN study, as you know, focused on patients who had prior exposure to a covalent BTK inhibitor. Patients were treated with Pirtobrutinib once daily, and there was a dose escalation phase, but the majority of patients received 200 milligrams once daily as the recommended phase 2 dose. We also included 14 patients with BTK inhibitor naive disease. So the results have been previously presented and published, of course, in a variety of formats, and this was an updated 2-year analysis of the survival results, in which we focused on different pre-specified high-risk subgroups to look at whether the overall response rate was different at all. In terms of the characteristics of the patients, there were quite a few patients with blastoid or pleomorphic histology, about 22%, and of the about half of patients that had TP53 status assessed, approximately half of those patients had aberrancy. And the interesting things that we saw were the overall response rate remained pretty consistent. It was about 57% overall, with a CR rate of 19%. And when you look at the subgroups, it was consistent across the subgroups which we looked at, with 2 possible exceptions. The simplified MEPI score high-risk patients had a slightly lower response rate. The patients who discontinued their prior BTK inhibitor because of treatment toxicity rather than treatment resistance or progression had a slightly higher response rate. But of importance for clinicians, both pleomorphic and blastoid disease and patients with TP53 aberrancy did not seem to have any impact on their overall response rate. When we actually looked at the response durability, progression-free survival, overall survival, again, it did not appear to be substantially different according to high-risk features, and duration of response was similar whether you had high or low Ki67, whether your TP53 was aberrant or not. So, and the safety signal from the study was really consistent with what we previously reported, with low rates of covalent BTK inhibitor-associated adverse events like bruising and arthralgia and hypertension and atrial fibrillation. They're all fairly infrequent. So I think the upshot of all that is that because it's now been approved in the US for patients with relapsed and refractory mantle cell lymphoma having experienced treatment failure following a prior covalent BTK inhibitor, it's now a good treatment option for people with that disease setting.